Good evening, everyone. Welcome to our webinar tonight. My name is Samia Al-Ataibi. I am the section head for partnership and collaboration department in Saudi Patient Safety Center, as well the patient safety officer for the WHO Collaborating Center in Policies and Strategies. I will be serving you today as a moderator. Prior to introducing the webinar topic tonight and the speakers, I would like to thank the attendees for the time and attending such an interesting topic, and to highlight the questions will be answered at the end of the session, and to post your questions at the Q&A icon. You can see it down at the bottom. So our speakers will be answering them gladly. You will be hearing a presentation tonight from Dr. Prof. Nabil Duidar, the Director of Health Governance Unit and WHO Collaborating Center for Patient Safety and Interprofessional Education, and Dr. Sally Mustafa, lecturer at the Medical Research Institute, facilitator for Health Governance Diploma, Alexandria University. Also, Dr. Iman Abul Khair, fellow lecturer at the Health Governance Unit, Medical Research Institute, Alexandria University. As well to Dr. Rimaz Abaid, course facilitator and Health Governance Unit, Quality Coordinator, Medical Research Institute at the hospital. They will be speaking to us tonight about patient safety through interprofessional practice, and the objectives will go around introducing interprofessional education and practice, present framework for interprofessional practice, demonstrate opportunities for collaborative practice, and elaborate on interprofessional context of medication safety. Starting with Prof. Nabil, he is a professor of general surgery in the Medical Research Institute, Alexandria University. He graduated at Egypt. Prof. Nabil had a several administrative posts, including the Research Institute, is an advocate of patient governance. WHO Collaborating Center for Patient Safety and Professional Education at Alexandria University, Egypt. Glad to have you, Dr. Nabil, presenting with us at the SPSC webinars, and to have the two centers of WHO Collaborating Center Patient. Yeah. Tonight
very much. Pleasure for me to be here.
Thank you. I'm sure that our attendees tonight will learn a lot from your work, you and the team. And you can start.
Thank you, Ms. Samia. Thank you very much. Good evening, everybody. First of all, I would like to thank the Saudi Patient Safety Center for inviting us and giving us this opportunity to talk together about patient safety from the perspective of interprofessional education. I have with me today from the Health Governance Unit in Alexandria, Dr. Sally Mustafa and Dr. Iman Sayed and Ms. Ramaz Hussein, and they will share in the presentation accordingly, and they will present themselves at the time. What we would like to cover today together is give a background of interprofessional education and collaborative practice, and why is it considered an important issue these days. Also, we would like to present a vision for the interprofessional education, and also a framework for implementing interprofessional education and collaborative practice in our work. We also would like to present some of the work we done in our unit in our initiative to advocate and to implement and to create an awareness of the importance of interprofessional education and collaborative practice. And also at the end of the webinar, we would love to exchange our experiences and your knowledge together. We all know that we have a problem in the health care sector. I will not go into the details of the numbers and figures. I'm sure you all know that we have a problem with the quality and the patient safety in our services. And unfortunately, healthcare nowadays is considered more dangerous and more risky than just simply driving a car, and even more dangerous than the aviation system. That is why at the beginning of the century, the Institute of Medicine published its important report, To Err is Human, based on the unacceptable levels of adverse events facing our patients when they are in our care. And this report recommended 4 basic steps to take. First of all, to create a critical or core knowledge about patient safety, and to encourage leadership within the field of patient safety. The second recommendation was that we have to identify and learn from our mistakes. Also, we were encouraged to start to set standards for safe practices and what we expect from ourselves or our colleagues as regard their performance and their safe approach to their patients. And in the end, also, the Institute of Medicine recommended that each institution should have within it a safety program, a patient safety program. A year later, another important report, also from the Institute of Medicine, came out, called Crossing the Quality Chasm. And within that report, the Institute of Medicine recommended that there should be improvement, continuous improvement in 6 domains. And these domains nowadays form the most common framework for, or common definition for quality. That we all have to work together to improve safety in our hospitals and healthcare system, that we have to introduce effective interventions, and that we have to be patient-centered, and our interventions have to be offered to patients in a timely manner and efficiently and in an equitable manner. So that was an important report introducing the quality framework, otherwise known as the STEEP framework. 2 years later, another report came up regarding our education. How should healthcare providers be educated? In specific, what competencies we should acquire. What is important in this report is that it is directed to all health professions. And that is what we mean by that: doctors, nurses, pharmacists, dentists, technicians, all people working in the health sector, that they should acquire a set of competencies. We all should acquire this, enabled to be able to work together for the sake of our patients' safety and, of course, benefit. These competencies is that we have to understand what does providing patient-centered care means, that we should be able to work as teams formed of multiple disciplines and multiple professions, what we call work in interdisciplinary teams. We should also acquire, all of us, how to implement evidence-based practice through implementing evidence-based guidelines. And we should also know how to apply quality improvement initiatives, and to use informatics And when we talk about using informatics, we don't just mean the use of IT. No, it is to appreciate also the value of data, information, and knowledge in the management of our patients and of our services, and utilizing it to improve it and to make it more safer. So these are three important documents which have shaped the healthcare system all over the world and has emphasized the need for the future healthcare providers. And this shows this is just an illustration showing the 5 competencies that we all should acquire. That we, first of all, we should understand what patient-centered care is and how we can offer it. We should be able to work in teams and utilize information to offer safe practices and to improve our practice. On the same track, but 10 years later, the WHO published its famous framework for action on interprofessional education and collaborative practice. And it is this document that we are really following these days to try to create this concept where we learn together to work together. And before I go further, I would like just to explain the definitions of what is meant by interprofessional education and what is meant by collaborative practice. Interprofessional education is basically, it occurs when students or any individual from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Of course, when people acquire the skills or experience interprofessional education, they may also acquire another skill of knowing how to work with different professional backgrounds, working together with patients, families, carers, and communities to deliver the highest quality of care. So what we have to notice here is that collaborative practice, it means that we have to work with our colleagues and with patients, with our patients and their families as partners of the same team. This might require from us a paradigm shift in the way we think about our practice and how we should approach it. Why is the WHO interested in interprofessional education and collaborative practice? Because there is enough evidence now around us to say that effective interprofessional education leads to effective collaboration. And both of them, they strengthen our health system and they improve health outcomes. What the challenge is here is that this requires the cooperation of the health system and the education system. There should be more integration, and we should really be teaching or being taught what we will practice. And this is the framework for action which the WHO has produced. And here it is illustrated that to a certain extent, we have a fragmented system in the sense that doctors and nurses and pharmacists and dentists, we all have our own schools and they all learn on their own, and they rarely meet together to learn together because in the future they might be working together. So if we have interprofessional education, then we can have, or we can produce, or our schools can produce what is known as collaborative practice-ready health workforce. And then so we can start to introduce collaborative practice, which we hope will strengthen our system and improve the health outcome of our patients. In its document for promoting interprofessional education, the WHO recommends certain learning outcomes to be acquired by healthcare providers. Of course, there are many other associations and societies who are also calling for interprofessional education. However, most of them call or recommend to acquire competencies related to teamwork, understanding really our own roles and responsibilities in the service and those of others, because it's very important to be able to work with other people and to respect them, is to know what their role is and what their responsibilities are, and to accept them and to deal with that situation. Also, how to communicate without conflict, and to learn and reflect together, and to create positive relations with our patients, and also to practice in an ethical manner. So to acquire such an approach, the WHO recommends three phases with 6 actions in order to advance interprofessional education in our sector, healthcare sector, and also in the relevant educational sector. First of all, we have to contextualize interprofessional education. Interprofessional education on its own is weak, but when it is contextualized to our local environment or to a certain subject or to certain subjects, it becomes very strong and powerful. So this is the first step, and we do this through creating a common vision and a purpose, and we develop the relevant curriculum. Once we do that, we start to commit our resources and our time and our staff to this initiative. So of course, because interprofessional education and collaborative practice requires new approaches in education, of course there is a need to train staff and to dedicate some resources for that. And after that, we have to, as step number 4, we have to find the opportunities, which might be challenging, as we can see later. Where are we going to introduce interprofessional education in our curricula, and whether we're going to do it as a whole or partly in certain areas. Of course, during this process, there should be institutional support from the leadership and from policymakers. And the third phase, which we call the championing phase, is that we, in the end, should share our experiences and successes in order to show others that this is interprofessional education is possible, and to show people the positive outcome of such an approach. What we will present now in the future, in the coming slides, is our initiative or attempt in our unit to implement and start the creation of an awareness or a critical mass to support interprofessional education. So the first step, as we said, we wanted to create a common vision and a purpose for interprofessional education. So first of all, of course, we are introducing interprofessional education within the context of patient safety, because we think that patient safety is a good media for collaboration and teamwork. And it is the concern of everybody. It is the concern of all professions and also the concern of our patients. So our vision for interprofessional education in the area of patient safety is that all health professionals are competent to deliver safe, patient-centered care as team members that appreciate interprofessional education and collaborative practice and are capable of utilizing informatics to continuously improve the safety of the services. So in this vision, there are key terms such as all health professionals, patient-centered care, teamwork, utilization of information, continuously improve, and offer safe practices. Second step, like I said before, in contextualizing the interprofessional education, we should develop the curriculum. And we would like to show you how we developed the framework and part of its content. In developing the framework for interprofessional education in patient safety, we utilized the common competencies recommended by the Institute of Medicine. So our framework, as shown here, is centered around engaging patients to offer safe practices. And then we also have to acquire competencies to know how to working in team and how we can practice safely and how we can improve the safety of our care or our services. And in doing so, how to use data, information, and knowledge that we have to do so. So I would like to ask my colleague, Dr. Sally, to tell us how she and her colleagues developed the content of working in teams in our unit. Please, Dr. Sally.
Thank you, Dr. Nabil. Thank you. Good evening, everybody. First of all, it's my honor as well as my pleasure to join you today in this webinar, as it's our aim at the end of the day to deliver a patient care which is both safe and integrated. Okay, now we shall start with how we proposed or how we developed a methodology for developing a curriculum for working in teams as being a milestone in the interprofessional education curriculum framework. First of all, we at the unit, the health governance unit, we were absolutely affirmed that working together and learning how we should work together as well as we learn together, despite of our professions and our hierarchy, our expertise, it's all goes to the patient safety and how we deliver their care within the integration of patient safety or the concept of patient safety. Okay, working in teams, it was identified by us as being the first domain to tackle in developing the interprofessional education curriculum. We have selected or gathered a group of experts together from the core group of our unit, Alexandria University professors and educators, as well as healthcare providers. We identified such a group and we via emails, we have to introduce or reintroduce the concept of interprofessional education and how it's crucial for the working together and working in teams. It's crucial for the delivery of integrated patient care. And we suggested that what would they suggest to be included in such a curriculum. The responses were categorized. There was very motivated and they were very eager, and we had a great response from them. These responses we categorized in 5 main domains. First of all, the team working, the topics we had to introduce in this curriculum were team structure, including the definition of a team, types of teams, roles and responsibilities, and as well as leadership. Secondly, the team culture and climate, and what identify a team and how it acquires its identity and the interdependency of a team, and so. Third, the team processes. It's the way the team is going to perform in order to achieve its ultimate goal. And number 4, it was reflexivity, which indicated that the team itself reflect on its mission, on its goal, on the way it acts, and on its action plan, if there is any alternatives that should be incorporated. And finally, how do we have tools for this teamwork, or what shall be introduced for the teamwork to facilitate its work, either in the leadership as well as the mutual support and communication. Okay, we have a team. It has a goal. So this goal, it comprises many tasks. As for us to prevent juggling of these tasks, we have to subdivide our work or our action into episodes. Okay, it's the episodes, it's the way that the team has to perform within it. It starts with an input, a team feedback. Then it's the team process, the action we are doing. It comprises the transition process, the action process, as well as the interpersonal process. Okay, and then at the end of this episode, we have the outcome that we were looking forward to. Okay, by these episodes, we have to learn that these episodes, every episode has its length within time perspective, as well as its weight. Some are light, some are heavy, and every episode identified its task that has to be done within this episode. Okay. Within the episodes, it's the way that the way that the team starts to act is the team process. Okay, doctor, please. Yes. Okay, as we've said before, there are 3 phases for the teamwork processes or teamwork. Yes, first one is the transition. We perceive transition phase as a preparatory phase. It's a preparatory phase where we can prepare for the work ahead. Also, we can look forward and backward. What are we going to do and what was done? Okay, the feedback from other episodes, it's crucial that when we start the transition phase. Okay, first of all, we have to analyze our mission and our purpose from it. Secondly, we have to be specific about our goals and what we are aiming to. Third, the strategy and planning. How are we going to accomplish this and what is our action plan? Okay, then comes the action process. The action process, it's the how well do we perform? How well do we perform? In this phase, we should monitor the progress towards our goal. How much did we achieve? Is it enough? Is it has to be revisited or reconstruct again, or backup plan or so? The team should have monitoring within them between each other and inter-team, and then they should coordinate their work together. Okay. Within these 2 phases, the transition as well as the action phase, we should say that there is another phase that comprises these two phases, which is the interpersonal phase. Within the interpersonal phase, it is here we should say that it's the way that the teammates can work together. How do they see each other? How do they manage their conflicts? Every team has its own conflicts. So how do they manage their conflicts? How do they motivate each other? How do they build their confidence? And so, how do they show their affection? How do they see what is appropriate to be done, or what's appropriate to be said and what's not appropriate? Okay, but here we have to recognize the difference between the teamwork process and the between the teamwork process and the work that is done. Simply, we can go with our mission that we asked a group of expertise to send us a group of topics that should be included. Okay, sending us this responses, it is perceived as the teamwork process. The search they did and how they wrote it down, and so it is the work that was done. This is how we differentiate between the teamwork and the team process. Okay, then comes the emergent state process. The emergent state, yes. Dr. Nabil, yes. The emergent states. The emergent states, we perceive them as intellectual capabilities of the teammates themselves, and how they communicate with each other. How do they communicate with each other? Do they have shared mental models? Do they mutually trust each other? Do they have the freedom to speak up and to say their opinions and say if there's something is wrong, and they are heard, and what they are saying or what they are suggesting, is it being heard and it's being gone on with? There's no fear on saying this terms, and how collectively and efficiently they work together. Okay, these were the one of the topics that were we found that was very important in the curriculum of the teamwork. Thank you. Doctor, would you please? Yes.
Thank you, Dr. Sally, for elaborating on this important aspect of teamwork and knowing that there is something called team processes, and they have two phases, a transition phase and an action phase. And it seems that also the interpersonal processes is very important between team members to produce what is known as the emergent state, which ensures a shared mental model and mutual trust and psychological safety for people to work together in a transparent manner. Thank you very much. And now I would like to ask Ms. Ramaz to tell us about how we can engage patients, and she can also tell us about the framework which was developed to help us engage patients. Ms. Ramaz, please.
Okay, Dr. Nabil, Assalamu alaikum. Good afternoon all. First, I want to thank Dr. Sally, Dr. Nabil, and our audience. Before I start, I shall introduce myself. I'm Ramaz Ahmed. I'm a course facilitator at Health Governance Unit and quality coordinator in Medical Research Institute. Of course, I am with a nursing background. So simply, first, we will elaborate the meaning of patient engagement. Patient engagement simply means that patients and families with caregivers working together actively to collaborate to improve our healthcare safety for better clinical outcome, of course, and quality improvement. This is the most simplest definition we can get. Okay, when we asking ourselves why patients and family, we will find that Patients know their symptoms and the responses to treatment better than anyone. Of course, we are all patients, but when we were sick one day, we of course feel our symptoms. We know what we have, what we feel, and we can express better than anyone. Also, we are noticing any changes physically or any errors with ourselves, and also we can know our new drugs, know our multi-prescribers. Patients very highly invested in their own well-being and outcomes also. And finally, the family themselves spend many hours and a lot of time beside patients and at home. This all can consider to be as factors that we have to engage our patients and family in our curriculum of IPE. Thanks, Dr. Michael. Second. Previous slide. Okay. So here we propose a framework for patient engagement. This framework honestly was done in our unit, the governance unit, and it was done based on participants that we gathered from Alexandria University, physicians, nurses, our educators, and so on. Participants worked together as a group on a group discussion to identify what is opportunities and the challenges related to patient engagement to be considered. And the result of this group discussions, as you see in this framework, they do affinity map according to the brainstorming ideas and produce the 4 levels of opportunities or areas. We can say different levels or areas of engagement. These areas, as you see, clinical care, also the health services, policy making, and research. So in the patient engagement framework we will work, or we have opportunities to work in those 4 areas. Also, in the form of engagement, in the forms of engagement, as you see, we have 3 levels of patient engagement produced by this affinity map. We shall start with an enlightening level, then the consultating level, then the empowering level. These 3 levels of engagement show us to what extent we can engage our patients in the areas of engagement we mentioned before. So if you see in this framework, by producing the area of engagement and the form of engagement, we had 12 cells. Each cell considered an opportunities to work on to engage our patients. I will give an example for the first cell that combine the safety of care or clinical care with enlightening or informing the patient as a level of engagement. So in the safety of care, in the enlightening level, we can do an open communication. Also, we can educate our patients to recognize their health needs. Maybe they don't have the abilities. We can talking honestly to our patients if any safety incident occur. No problem in that. Tell them what happened honestly. Provide information about diagnosis, treatment, and the plan. Using animated videos, you can use emails, social media technology, so to better contact with your patients. Patients are given handouts, booklets that describe any procedures they're going to have, diseases, diagnosis, whatever. And this is all simplest methods or examples to engage our patient in safety of his care. So if we are leveling our engagement to consulting our patient, what we can use, you can use educational materials. You can provide safe space for patients and carers to voice their needs and concern. Also, we can encourage patients to ask questions. We can give them simple tools like Ask Me 3, which I had asked my patients. These all tools we can teach this to our patients so they can use it. Patients are asked about their preferences, treatment plan. Okay. I think the higher level of the continuum of patient engagement is to empowering our patient. And for that, if we use this level in our safety of care area, we can encourage patients to be active partners. So here, our patient is now my partner. Example, tracking and plotting of their medication using relevant laboratory results from HIS. Patients can collaborate with clinicians through portals or partnering with patients to plan, deliver, and evaluate their care. Here, we work together to deliver the care. We are here co-leading together the treatment and plan of care. This was an examples of patient engagement. Also, participants asked what about the challenges that you can face or we can face to engage our patient. And we had these three influencing factors of their answers. They had human factors, organizational factors, and regulatory factors. Highlighting these factors, please.
Ms. Ramaz, can I just, sorry to interrupt you, but Ms. Samia, you're raising your hand. Have you got an issue?
Sorry, Dr. Nabil. Yeah, sorry, it's a technical thing.
Okay. Okay. Sorry, Ms. Ramaz.
No problem. Okay. Next slide, please. Next slide, please.
You want this slide or the next?
Next.
You have explained it?
Yes. I finished this slide.
Okay.
We will mention some examples of the influencing factors that may interfere the patient engagement process, like human factors. Human factors may consider like the patient's knowledge and patient attitudes. Okay, some patients or many patients prefer to have simple data or how simple to know basics only, and other patients need every detail about their condition. Also, demographic characteristics. All the patients not like youth, not like a child. Patients' beliefs about their role, health literacy and education. Of course, education can prevent the patient from understanding the diseases, treatment, or options. And other factors like unwilling patient to participate in their care. They are passive, not active patient. To show the organizational factors, we can say that the cultural barriers and the lack of leadership commitment can be one of the factors that can hinder patient engagement. Also, policies and the practices, insufficient training of the doctors, nurses, how to build a strategy to engage a patient, how to communicate effectively. Also, the limited availability of the technology. Regulatory factors, as our participants described, they found that policies, bylaws, accreditation, educational framework, professional development framework, all these are factors that can hinder the patient engagement process. And that's all. Thank you all. And I will leave the floor to Dr. Iman. Okay, Dr. Iman, you can start. Thank you.
Thank you, Ms. Ramaz, for this detailed explanation of the framework for patient engagement, which I think is very useful to guide us in our educational activities and even to guide us during our practice. Now, it's my pleasure to give the floor to Dr. Iman. She will explain to us how we can teach or how we can also implement the concept of practicing safely. Dr. Iman.
Hello, everybody. Thanks for joining us in our webinar. Today, I will talk about the dimension of practicing safely as a dimension of interprofessional education framework. First, I will start by safety approaches. We have two safety approaches, safety one approach and the safety two approach. Safety one approach asking the question how to minimize harm. It focuses on learning from error. It's about find and fixing the error. Safety two approach asking the question how to adapt safe, effective care in our everyday clinical care activities. It focuses on spreading safe practices and embedding safe practices in our everyday clinical care activity. Actually, both approaches are important and should be embedded in our healthcare system, but I will focus on safety two approach, how to embed safe practices in our clinical care practice. For practicing safely, health care professionals need to acquire principles about safe practices along the patient care pathway. This is our locally developed patient safety pathway. We developed it based on Egyptian accreditation patient safety standards and the International Patient Safety Code. It illustrates and identifies the opportunities of safe practices along patient care pathway, starting from patient admission to patient discharge. For example, upon patient admission, there are two opportunities for safe practice. Such as patient identification and medication reconciliation. Also, it identified the spaces for interprofessional collaboration toward patient safety. For example, the organization should identify how team collaborate for medication reconciliation properly, how team will collaborate to communicate the critical lab results properly, how they communicate together during handover, and so. For practicing safely, also healthcare professionals need to understand and have access for evidence-based medicine and evidence-based research to integrate their clinical expertise with the best available evidence with consideration to patient values and patient expectations. This is the second approach for practicing safely. This is one of the best approaches or strategies for practicing safely and embedding safe practices in our everyday clinical care activities is the integrated care pathway, and also it an opportunity for collaborative practices among the multi-professionals. It a locally agreed multidisciplinary evidence-based practice. It focuses on a specific group of patients, for example, pregnant women, stroke patients, diabetic patients, pregnant women with heart diseases, for example, because it should be developed specifically for based on patient-specific needs. After that, it becomes a part or all the clinical record, which is facilitate the recording of care, the delivered care at the point of care. Why integrated care pathway? Integrated care pathway is aiming for giving the right intervention in the right order, in the right place, at the right time by the right healthcare professionals. And at the end, we will achieve the right outcome, all with consideration and with giving a great attention to patient experience. The component of integrated care pathway, first we should identify the scope, identify our team, the design, the recording document, and the variance analysis. This template is for enhanced recovery after surgery pathway. An example, I will explain it later. The first step is we should define our scope based on well-defined objective. We should define the starting point of our pathway and the end point of our pathway. It could be developed for the following section: primary care patient management, secondary care management, or social care management. For example, we could develop it for monitoring of the pregnant woman at the primary care setting, or her management during hospitalization till discharge. And so, depending on our defined objectives. After that, we will develop our team. It's definitely a multidisciplinary team, including physicians, nurses, pharmacists, and any related discipline, where every discipline is equally important and all their inputs are respectful. So it helps in defining responsibilities and roles, and make team understand the responsibility and the role of each other, which will minimize definitely the duplication, will promote the communication at all levels, will promote the collaborative practice, and also will promote the integration between the primary care setting, the secondary care setting, and the tertiary care setting, which will improve and enhance the continuity of patient care. After that, we will start as a team in developing the design of, in designing our integrated care pathway. We will start by identifying the agreed upon best practices for the expected care aspects for assessment, pain management, medications, diagnostics, treatment, nutrition, education. All the team should get a consensus about the best practice based on their local situation and based on their organization capacity. The end product of this step will be the agreed upon best practice. After that, they will assess and analyze the current patient care journey by doing a process mapping for the current practice. It will be developed from patient perspectives and the care provider perspectives. This is a very important step. So I wanted to highlight here that one of the ground rules in this step is no blame, to allow all the team to interact together, get together, interact freely to identify if there is any delay, if there is any something missed in the current practice, or something repeated or duplicated, and so to evaluate their practice, identify any opportunities for improvement. This will be the template or the end product of our integrated care pathway. This template shows us the starting point here, the phase or the phase and the scope, which identify the starting point and the end point. It will identify the steps, which is including the activities or the planned care steps. It will identify the staff, the responsibility of everyone. On the right section, this is a part of the recording. where the care provider document their implementation. Yes, it means that this item is implemented. Not applicable mean this is contraindicated. V for its abbreviation for variance. Variance mean it deviated from the planned care. Due to any reason such as patient refusal, unavailability of resources, lack of expertise, as you can see this part for variance recording. Here we will record the step of variance. We will describe the variance or the issue and the action taken if there is any alternative given to the patient. We will document the code. What is the code? The code related to the variance code. The variance codes, if it patient related, staff related, hospital related, or family related, and there is part for the care provider signature. Actually, this part is the unique part of the integrated care pathway because it distinguishes the care pathway from our multidisciplinary care plan, because it provides us the chance for real-time audit of our clinical practice compliance and help us to tracking the variances. This is the most important step. We should identify and track and analyze our variance and identify and investigate the most common causes for improvement and modification. For summarization, at the end, I want to show us and stress if you looked at how integrated care pathway fit with safe practices, how it helped the healthcare team to utilize the evidence-based guidelines, how it allow for real-time clinical audit for our clinical care standards, how it promote better recording and documentation and clinical records keeping, how it help in risk identification and management. Really, it's a bundle of safe practices which will be embedded in our daily clinical care practice. And thank you. Thank you for your attention and time. Thanks,
Thank
Dr.
you.
Nabil. I will give the floor for you.
Thank you, Dr. Iman, for this detailed explanation of the use and the value of integrated care pathway in assuring the safety of our patients and how it can be a valuable tool in our educational programs and also in our practice. To sum up and to come back to our to the action steps recommended by the WHO, what we have been presenting are basically the first 2 points, which is the contextualization of interprofessional education. And you saw how once you can contextualize the issue, it becomes of great value. The second phase is the phase of commitment. Once you contextualize your activity, you have to start to commit your resources, especially your human resources, the time and the financial resources. And after that, you'll have to start to think where in the educational programs can you introduce interprofessional education. And you can see here that IPE and collaborative practice requires staff training because it cannot be delivered through the traditional methods of education, or the traditional methods of education, although important, are not really the most appropriate. Interprofessional education requires adult learning and such as problem-based learning and team-based learning, and reflective learning. So institutions have to make sure that their staff can deliver such educational strategies, and to ensure the contextualization of their curriculum content. There has to be also case scenarios from the real life scenarios or patient safety stories that through which the program can be delivered. Also, the challenging part is to decide where can we introduce interprofessional education. Of course, you can introduce it in the undergraduate education and the internship. You can introduce it into the postgraduate training, whether it is basic or the advanced. It also can be an essential component of continuing professional development. This decision is up to the local situation and the logistics and the opportunities available. Lastly, I want to say that it's also very important, especially in the early phases, that we share our experiences together with such initiatives like the interprofessional education and collaborative practice attempts. And in our unit, we have started what we call the ABC of patient safety, through which we have produced 2 issues, and we intend to produce more, through which we will share with anybody who's interested in the topic, our understanding and that of others on interprofessional education and how it can be implemented and how it can lead to collaborative practice. Interprofessional education and collaborative practice is a good strategy for strengthening our health system. However, it's a challenge because it needs the integration of both the educational system and and the health system. And this shows the maturity of the system or the systems we have. And I hope that you or us can achieve integration in such environments that we have. I take this opportunity to thank you all, and I hope you found the topic interesting. And I will give the floor to Ms. Samia to take over. Thank you.
Thank you. Thank you very much, Dr. Nabil, Dr. Sally, Iman, and Dr. Ramaz for discussing and elaborating and addressing such an interesting topic. I would like to emphasize on our attendees, if you have questions, please go ahead and post it in the Q&A icon questions. Starting with Dr. Nabil, we have questions here from one of the attendees asking, what are the principal obstacles against interprofessional education, and how can we improve the healthcare professionals' collaborative practice in our healthcare system?
I will start with the obstacle. Of course, the obstacle, first of all, basically, simply, people might not be aware of it. So the first thing is the awareness. It's very important to have people aware of the topic and the importance of IPE and collaborative practice and teamwork. Second is to find the opportunity to offer such an education. And I think it is maybe it is easier to start with small workshops or small topics which are common between the various professions, instead of starting in a formal program entailing a lot of logistics.
Thank you, Dr. Nabil. And going back to Dr. Iman, since it was the last presentation, so we have a question here asking how integrated care pathways improve patients' outcomes, especially in relation to patient safety. Dr. Iman, I believe your mic is mute. Thank you.
Thank you.
Actually, as we looked at how it impedes the safe practices such as risk assessment, prophylaxis in our everyday activities and in our clinical care, which definitely accordingly it will improve patient safety outcome. There are many studies actually reporting how it decrease significantly the venous thromboembolism after surgeries, how it decreases the rate of infection, how it promotes the use of prophylaxis, especially among surgical patients for venous thromboembolism or anti-thrombotic prophylaxis, because about less than 50% of surgical patients receive the adequate amount of antithrombotic during surgery, and about 50% of surgical patients is reported by studies developed surgical complications after surgery, such as infection or venous thromboembolism. And
so emphasizing on the effect of the integrated care pathways on patient safety, it's leading to another question: how can we integrate it to promote interprofessional collaboration and as well to promote patient participation as well?
It promotes interprofessional collaboration because as we looked in our presentation, integrated care pathway is developed by multi-professionals, physicians, nurses, doctor, pharmacists, and any related discipline where their all inputs are respectful and they are equally important. It enable communication, it enable interaction together toward achieve patient safety, understanding the responsibility of each other, which make working and the communication easily together. And it give them the chance to collaborate toward achieving the goal of patient safety. As regarding patient engagement, we can develop a version for from the integrated care pathway for patient engagement. It help in patient education. It help the patient to be a participant in our care plan, which is really a deficient area actually in our practice. And also it based and developed based on patient experience. Patient become a participant with us in process mapping, in identify if there is any problems in the current practice, any delay or any clinical risk. So it's a great chance really for patient participation in the interprofessional collaboration.
Thank you, Dr. Iman. And speaking of the patient participation, we have, I believe, I can see questions that maybe Dr. Ramaz can answer. Talking about the patient engagement framework, any recommended strategies or steps that can facilitate the implementation of the framework?
Okay, first we can begin by empowering our patients. We can encouraging them to speak up, telling us their concerns and what are the conditions or what is the problems that they face. We can teach our patients also or we can explain to them what they are facing, what is their conditions. Thus that we can empower our patients by making them actively involved in the care they take. Like in same as in medication, we have the 5 moments strategy. We can use the 5 questions strategy. Also, we can make our patients to be part in the decisions we take. We can empower them by giving us their IHS or how they will share in the treatment plan and so on. I think by this simple steps to start with, we can start to applying our framework of patient engagement.
Thank you, Dr. Ramaz. And empowering patients and families to prevent medical errors. It's sometimes it's a gap area that healthcare providers sometimes with the rush and during the care and everything they miss engaging the patients and doing the awareness to prevent medical errors. Would like to know if you have any recommendations or any messages for the healthcare providers to emphasize on engaging the patients and families and their important roles in preventing the medical errors.
Okay, healthcare providers face many challenges like lack of training of how to engage to the patient with patients. They may lack communication skills when they have a conflict with patients or their families. So we can start with training healthcare providers by giving them programs like patient engagement programs. Also, they face consuming times when dealing with or talking to patients about the treatment plan and so on. It may take more than 15 minutes for each patient, and this is a consuming time for doctors and nurses. And of course, shortage of the staff will hinder this process. So we need to find ways to collaborate with our patients in, you can say, minimum time, like online or find portals ways to engage with our patients, face-to-face consuming many times. Also, we can encourage the passive patients we dealing with to be more collaborative with us, giving them ways to be more active. And lastly, we need leadership commitment. We need leadership support and commitment to help doctors improve the strategy of patient engagement and collaborating with patient engagement more effective. I think so. Yeah.
Thank you, Dr. Ramaz. And we have a question for Dr. Sally. How can we distinguish between a team process form to a team state? And another question, what is meant by team process and where do they fit at different performance episodes?
Okay, first, if we want to distinguish between the team process and the team state, I can give an example to elaborate such a difference. Okay, now that we have a team that is that aims to has an ultimate outcome, that so within this team there's a conflict, okay, or a clash between the team members. This conflict, it's a team process. The conflict and how they manage it, it's a team process. Whereas the feeling of annoyance and the feeling of despair that the team members encounter or they feel, they have probably after this clash is a state. This is their cognitive way of getting such a clash or perceiving such a clash. You know what I mean? Yes. So this is one of the things that we can distinguish between both. Secondly, when we talk about the team process, we talk with verbs of action. Like I made a mistake, okay, or the team has made a mistake. So we should find a solution and we can fix it. This is how a team process can work, okay? Whereas when it comes to the team state, we use adjectives such as, I'm aware we have difficulties in perceiving our goal, but I have the confidence, or we are confident that we are going to overcome it to reach our goal. This is how we can distinguish between both team process and team states. Could you please remind me with what question? The second question, please.
Yes, the second question. I believe you answer half of it. So in the team process, where do they fit in different performance episodes?
The team process, it's the main bulk of the team. You mean the team process? Where does it fit in the team episode? It's the main bulk of the team episode. Yes, it's the team. It's the main bulk of the team. It's the activities or the action the team perceive with or undergo to. It's the way the team gets the job done. This is the way the team with preparing phase or transition phase, then the action plan and how they interpersonally react with each other. This is where it fits. Am I being clear? Yes.
Yeah, it is clear, Dr. Sally. Thank you. Going back to Dr. Iman, I have a question here asking, do you develop the ICPs independently at the outset as a part of larger CPG clinical practice guidelines development or adoption of a project?
We developed the enhanced recovery after surgery in our unit. We did a pilot for it in one of the teaching hospitals, but we don't have the chance till now for its implementation to monitor the results and the improvement based on its implementation, but it's evolving.
Thank you, Dr. Ayman. Hopefully it's clear for the attendees. And going back to Professor Nabil, we have one more question. What are the standards to be applied to achieve maximum benefits from interprofessional education?
That's a good question. I'm not quite sure. I mean, if there are standards, there are these recommended steps to follow, which I showed. The main part is the contextualization of the programs developed. Also, there are now several societies and associations which have produced a set of competencies that should be part of the curriculum for any interprofessional education. They mainly are concerned with teamwork, respect, mutual trust, learning and reflection, respecting roles and responsibilities. So these are the evolving, I can say, the evolving standards about interprofessional education. Also, through the definition, there is a minimum of that there should be two professions to be able to say that you have interprofessional education or collaborative practice working together. Also, in the same time, teaching. So in the teaching itself, there should be multiple professions in doing that, and also in the assessment. And I think the unifying part is the teamwork in practice. Thank you, Dr. Sam.
Thank you, Dr. Nabil. Hopefully I did not miss any of the questions. And talking and tackling such an interesting topic from the perspective of patient, engaging patient, healthcare professionals, organizations, and the ICP and the interprofessional education. I would like from all of the speakers, starting from Dr. Nabil and Iman and Dr. Ramaz and Dr. Sally, to have to send home messages for our attendees in this regard. Dr. Nabil.
A take-home message.
In summing up the whole presentations.
Okay. Before answering that, I was reading the questions, and there was a question about inquiring where they could get a copy of the patient safety stories. They can get it from the website, from the unit website. So I'm sorry to take a chance of that. But I would say my take-home message about interprofessional education and collaborative practice, it is about human beings. It's not about high technology. It is about human beings and how we perceive each other, and being tolerant, and especially within our healthcare sector. And it is high time that we all work as a team to overcome these problems we have, which other industries have done. And it's time, my take home message, it's time to change our culture, to change how we work, the working climate.
True. Thank you so much, Dr. Nabil, for this message. Dr. Iman.
My take-home message is everything I think is doable, but we have to start to do something, and be open for a change, and be open and ready, and collaborate together toward patient safety practices. And thank you, Dr. Samia.
Yeah. Dr. Ramaz.
Okay, I think I think that our patients is in a weak condition. They are in a weak condition, and engagement of the patients is not a quick fix. It needs efforts from the both sides, from patient and their families, and also from our side as carers or providers. Efforts in the form of awareness, education, training, and so on. So we need to collaborate more with our patients, forget the traditional way of treatment, and start to apply the innovative ways like IBE and collaboration with our patients. Thanks. Thanks for the audience and for Dr. Nabil and all the audience. Thank you.
Dr. Salih.
Yes, I believe that now it's the time that that all barriers should be dissolved between the professions, different professions that are incorporated in the health services. There should be no discrimination between health professions. We should dissolve all hierarchies, and they should work together for the sake of the patient, as Dr. Iman has mentioned, or Dr. Rahman. The patients are vulnerable, and they come to us at their weakest state. So we should collaborate together in order to perceive a best treatment that is both integrated and safe. And thank you for every and each one of you. It was my pleasure.
Thank you, Dr. Saleh. Professor Nabil, there is a question I just pop up in the Q&A that we would like to conclude with it, since we have like a few minutes for the closure. If we can just answer this one quickly. How can we measure the impact of interprofessional education?
The impact, of course, it can be measured through the processes itself, and through the items. I mean, like through measuring teamwork, through measuring how much evidence-based practices or safe practices are being implemented. It also could be measured through the number or the magnitude of improvement projects or related to improving safety, the availability of data and information for everybody. And then, of course, in the outcomes, it can be measured through patient outcomes, morbidity and mortality. Also, it can be measured through staff satisfaction surveys. And lastly, and most importantly, patient safety, patient satisfaction and positive patient experiences.
Great.
So it can be measured and it should be measured through a framework of measures, not through a single measure.
I believe it's clear now for our attendees. On behalf of the Saudi Patient Safety Center, we would like to thank you, Prof. Nabil, Dr. Sally, Dr. Ayman, and Dr. Ramaz, and the audience for the active participation. It was a great session, and we are so glad to have you joining us here as a collaborating center in policies and strategies and collaborating center into professional education. And let's call it a good and beginning of a start of collaboration for further sessions and webinars between the two of us. And a message to the attendees that we would like to remind them that the registration for the third SPSC Patient Safety Conference and Diagnostic Safety specifically is open, and you can register. And as a part of the Saudi Patient Safety effort to provide you with a timely topic and interesting topics, we would appreciate if you fill out the evaluation survey provided by the end of the session. Thank you, Dr. Nabil, again. Thank you, Dr. Sally, Iman, and Dr. Ramaz. It was really great to meet you. Really great to have you presenting with us. And I can see it is a very interesting topic, and the numbers of the entities is continuing to go up even for the last minute.